Good evening. My name is Monique Hill, and I am the producer of today's webinar. I'd like to welcome you. This is Texas Fertility Center's webinar on Fertility 101 with Dr. Kaylen Silverberg. We are sorry for the delay. We had a few technical difficulties, but I think we are all set to go. I just want to let you know that these webinars come to you every month free of charge. The webinars are the third Thursday of the month. And the next webinar, which is going to be on May 20th, is going to be, Do I Need IVF? And then the June webinar is going to be about exploring male infertility. So I hope you can join us. I did want to let you know that we will be stopping halfway through to answer some of your questions, and then we will stop again at the end to answer some more questions then as well. If you look on your panel, you'll see there's a spot up there where you can click questions. You can put your questions there, and then we will answer them and get to as many as we can. I do want you to know that your information is confidential, so please do not worry about any of that being disclosed. And if you find these webinars to be useful, we would love for you to pop on the website, which is txfertility.com. That's also where you can find out about upcoming events. And if you would give us a review, we would love to know how we're doing and what else you'd love to hear about. So for now, without any more delay, I'd like to welcome Dr. Silverberg.
Okay, well, I guess that's me. I'm hoping that you guys can hear me because I'm having a little computer trouble and I can't hear. But what I'm going to do tonight, first of all, I appreciate your joining us for Texas Fertility Center webinar. This is a presentation called Fertility 101. And what I'd like to do to start off with is I'd like to start with some infertility truths. And one of the truths is that infertility is the inability to conceive or carry a baby following 1 year of unprotected intercourse. And that's really the definition of infertility if you're 35 or younger. If you're 40 or older, the definition really is 6 months. So if you've been trying for pregnancy for 6 months or more and you're over 40, it's really time to get help. So the next thing is that infertility affects 1 out of 8 couples in the United States. That's right now about between 7.5 and 8 million couples in the United States. So it's really a lot of people. I get asked all the time if the instance of infertility is increasing or if it's not increasing. And the answer is it really actually is increasing. If you look at data, demographic data from around the world, you'll find that in fact, the instance of infertility does appear to be going up. And probably the main cause of that is women delaying childbirth, women delaying childbearing and attempting pregnancy. So we know that it affects 1 out of 8 couples in the United States. And we also know that only 15% of all couples with infertility seek treatment from a fertility specialist. And those numbers are really not changing much. I'm hopeful that now when the latest data come out, which will probably be another year or so from now, that maybe these numbers will change. And I think that it's very important because now we're starting to see that the work that we've been doing for years, advocating on behalf of patients to try and get improved infertility coverage, is actually starting to work. So we're actually seeing more and more companies that are leading the way and offering benefits for their employees. So it's a big deal, and I'm hopeful that these numbers will change in the very near future. The main thing about infertility treatment that I'd like for you to understand and make sure that you internalize is that you have to think about medicine in general. Most medical conditions are not curable. So if you think about it, we can't cure diabetes, we can't cure heart disease, we can't cure most types of cancer still, and we can't even cure the common cold. But yet we know from data that Mercer has published that if a fertility patient walks in the door of a reputable fertility clinic and sticks with the plan, by the time they walk out, there's an 80 to 88% chance that they will have been pregnant and or had a baby. So infertility treatment, unlike most other medical conditions, infertility is curable. If you look at the causes of infertility, in the old days, the most common cause of infertility was tubal factor. Treatment was really developed, the in vitro fertilization was really developed to treat tubal disease, and most patients who presented with infertility either had ovulatory dysfunction or tubal factor. Eventually, treatments became better, and more patients with male infertility started coming in the door. Infertility became less taboo, so more people with male factor came in the door, more types of ovulatory dysfunction. It was recognized that endometriosis was a common cause of infertility, in pelvic adhesions as well. So we had more surgical conditions come into the office as well. And we were able to develop good, effective treatments for all of these conditions. So the first thing I'd like to discuss after that overview is, when should you seek evaluation? Well, we advise women who are under the age of 35, if you've been trying for pregnancy for a year, it's time to go see a fertility specialist. Not just your OB-GYN, but a true fertility specialist. And let me digress for a second and talk about what a fertility specialist is. A fertility specialist, a reproductive endocrinologist, is somebody who has gone to 4 years of college, 4 years of medical school. Then they do an OB-GYN residency, which is also a 4-year program. During the course of a 4-year OB-GYN residency, all OB-GYN residents maybe experience 12 weeks or so of fertility training, but that's it. And so when they graduate as OB-GYNs, when they finish their residency and they open up their office or they join a practice as an OB-GYN, they've had about 12 weeks total in their entire lifetime of experience treating couples with infertility. True fertility specialists go on beyond OB-GYN residency, and they do a 3-year fellowship in reproductive endocrinology and infertility. And what that does is that allows you 24 hours a day, 7 days a week, 365 days a year times 3 for 3 years to do nothing but infertility, recurrent pregnancy loss, and complicated endoscopic surgery. And that includes in vitro fertilization. And so a true fertility specialist is actually a reproductive endocrinologist. And you can go a step further than that and become a board certified reproductive endocrinologist. What that means is you've done 4 years of college, 4 years of medical school, 4 years of OB-GYN residency, 3 years of an infertility fellowship. You've passed your boards, not only in OB-GYN, but also you've passed subspecialty boards in reproductive endocrinology and infertility. Very important. So that's what a reproductive endocrinologist is. So if you're a woman under the age of 35 and you've been trying to achieve a pregnancy for a year unsuccessfully, you need to see a reproductive endocrinologist. Now, if you're over the age of 35, some people say over 40, but we would say over the age of 35, then it's time to see a reproductive endocrinologist after only 6 months. You also need to go sooner because these guidelines are not hard and fast. You need to go sooner if you know there's a problem. If you know that you don't ovulate regularly, if your partner knows that he has a very, very low sperm count, it doesn't make sense to wait 6 months if you're over 35 or 12 months if you're under 35. You should go see a specialist right away. So if you don't have regular cycles every 28 to 30, 32 days, you don't have a period. If 1 month your period occurs in 15 days, another month it may be 45 or 60 days, you have a problem. Don't wait 6 to 12 months. Go see somebody now. If you know that you've had a previous pelvic infection, gonorrhea, chlamydia, things like that, and you suspect that your fallopian tubes may be damaged, go see a specialist right away. If you've had a history of previous pelvic surgery, increasingly severe pain with your period, increasingly severe pain with sex, go see a specialist right away. You don't need to wait 6 months or 12 months. So what happens when you go see a specialist? Well, the first thing that's going to happen is we're going to take a medical history. We're going to talk to you about how old were you when you had your very first period? What are your cycles like? How often do they occur? Do you have cramping with your period? Any breast swelling or tenderness during your cycle? These are things that can tell us that you ovulate regularly. So if I talk to a woman and she says to me, you know what, I've got cycles every 28, maybe 30, maybe 32 days. My breasts get tender before my period starts. I've got pretty moderate cramping when my period occurs. You can pretty much take it to the bank that she ovulates. On the other hand, if I talk to a woman and she says, gosh, I really can't tell when my periods are going to occur. 1 month they may be regular, every 30 days, but then I may go 2 or 3 months and not have a period at all. And that happens a lot. Well, she doesn't ovulate regularly. And so that's important to know because we can treat that very easily. We'll then ask questions like, how old were you when you became sexually active? Did you ever use birth control pills or an IUD? How long have you been trying for pregnancy? Has your OB-GYN done any kind of fertility testing? And we'll build upon that and then develop our plan. We'll then go in and assess the anatomy. So we'll go in and we'll do an ultrasound, a vaginal ultrasound typically. And when we do a vaginal ultrasound, we're looking at your ovaries because ovarian size is important. It's a good predictor of how many eggs you have left. And let me digress again for a minute. So under the heading of life's not fair, men and women are very, very different. Guys make sperm all day, every day, from the time we go through puberty until a couple of days after they put us in the ground. Women, on the other hand, are born with all of the eggs they're ever going to have. In fact, that's not even totally true. 20 weeks before delivery, a woman has 15 to 20 million eggs. By the time she's born, 20 weeks later, that number's down to 6 to 7 million eggs. By the time she goes through puberty, that number's down to 300,000 to 500,000 eggs. And by the time she's 40, she only has on the average about 10,000 eggs left. So if you just do the math, by the time a woman is 40 years of age, she has literally burned through 99.9% of her eggs. And as many of you have heard me say, this is unfortunately not a save the best for last kind of game. So as women age, their eggs age. So your eggs, remember if I said that you had all the eggs you were ever going to have 20 weeks before you were delivered, your eggs are about a half a year older than you are. So if you're 35, your eggs are 35 and a half. If you're 39 and a half, your eggs are already 40. And it's important to understand this. So when we go in with your first visit, we'll do a vaginal ultrasound and we'll look at your ovaries to see how big your ovaries are. Ovaries should measure about 3 by 2 centimeters, 20 by 30 millimeters. And as you get older and as you run out of eggs, your ovaries will tend to contract and get a little bit smaller. We can also evaluate your eggs with a blood test. We use a lab, the largest fertility lab in the world, called Reprosource, are based in Boston. And what we'll do is we'll ask you to go get your blood drawn on day 3 or day 4 of your cycle. And when you do that, your blood will get shipped off to Boston to Reprosource. We'll get a report about a week later, and it will list 5 different hormones that we look at, but we primarily only look at 3. We look at a hormone called FSH, we look at a hormone called estrogen, and we look at a hormone called AMH. So let me go backwards. AMH stands for anti-Müllerian hormone. It's a complicated name. Don't worry about what the name is. It's just call it AMH. And what AMH is a hormone made by the immature eggs in your ovaries. So the more eggs you have left in your ovaries, the higher your AMH level. As you run out of eggs, your AMH comes down. Eggs are stimulated to develop by a hormone called follicle stimulating hormone, or FSH. And FSH is made by a little pea-sized gland that lives behind your nose called the pituitary gland. When your ovaries are loaded with eggs, your pituitary gland doesn't have to work very hard to make those eggs grow. So your FSH level is low. As you go through your eggs, as you go through your reproductive lifespan and you burn through your eggs, your FSH level has to get higher and higher and higher to stimulate egg development. And this is why we can assess ovarian reserve also by looking at day 3 FSH levels, because when levels are low, we know that women have lots of eggs left because not much FSH has to be produced to cause those eggs to develop. But as women run out of eggs, the FSH level gets higher and higher and higher, and that becomes a challenge and a problem. We're also going to initially assess sperm function. So we're going to ask your partner, if you have a partner, to go give us a sperm specimen. And we'll talk about sperm in just a few minutes. So let's move on a little bit and let's talk about the assessment of anatomy. Well, how do we assess pelvic anatomy? Well, one thing we do is this vaginal ultrasound. And again, that allows us to look at ovaries to determine, to make sure that they're the normal size. We can also look at the uterus to make sure that the uterus has a normal size, has a normal shape. We look at the wall of the uterus to make sure there's nothing there like a fibroid tumor, which is a benign tumor of the muscle wall of the uterus that can adversely affect fertility. We can also, most of the time, if we look mid-cycle especially, we can assess the shape and the consistency of the uterine cavity. And we also can look at the thickness of the uterine lining. So for example, before we do an embryo transfer, we want to make sure that the uterine lining has achieved a normal thickness, which is at least 7 millimeters in our hands. Some programs go for 8 millimeters. Some programs say 6 is fine. We're middle of the road at 7. And so we can assess all of these things with a simple single vaginal ultrasound. Another thing that we can do is we've got to do a better job of assessing the fallopian tubes. And the only way we can really assess the fallopian tubes non-surgically is to do an X-ray called a hysterosalpingogram. I know it's another long, complicated word. Sorry, we have a bunch of those. We call this test the Hsg, Hysterosalpingogram. And what the hysterosalpingogram, or the Hsg is it's a test where, in our case, the radiologists, in some practices, the physician themselves, will insert a little catheter, a little tube, through the vagina into the cervix, inflate a little balloon, and then inject dye to fill the uterine cavity and go out the fallopian tubes, while a big camera on the ceiling takes pictures. And we can then get printouts and we can look and see to make sure the uterine cavity is in normal shape, normal size. We make sure there are no filling defects in the cavity like polyps, fibroids, anything like that. And we can also assess the fallopian tubes to make sure that they're open. Very, very important. Another way that we can assess the anatomy is a surgical option. That's a procedure. There's two procedures. One's called laparoscopy, where we look through the belly button. Another is called hysteroscopy, where we look through the vagina. So laparoscopy is a minimally invasive surgical procedure where in the first half of your cycle, we'll take you to the operating room. The anesthesiologist gives you some medicine in your IV that looks like milk, and the next thing you know, you're on a beach in the Caribbean drinking margaritas for about for a little while, probably about an hour. And what we then do is we make a little bitty incision the size of the tip of your little finger in your belly button. We insert a needle and inflate your abdomen with carbon dioxide gas. We then make one or two other little bitty incisions just below the top of the pubic hair line, one on the left, and if necessary, one on the right. And those are for our toys, our laser, scissors, graspers, surgical instruments we need to use. We then put a telescope, an operating telescope, with a very powerful light source and a camera through the belly button into the abdomen so we can see what's going on. We can look at your liver, we can look at your gallbladder, we can look at the appendix usually. Mainly we see the uterus, the tubes, and the ovaries. And that allows us to determine whether there's any tubal damage. It allows us to look for endometriosis, which we'll talk about in a minute. It also allows us to look at the outside of the uterus, looking for fibroid tumors, things like that. Anything that can interfere with the ability of the egg to develop in the ovary, make it into the fallopian tube, and then make it down into the uterus, and hopefully implantation can occur. So again, the main things we screen for laparoscopically are endometriosis, fallopian tube disease, and uterine fibroids. Well, there's another surgical procedure called hysteroscopy, where we can actually take a different operating telescope without making any incisions, pass that through the vagina, through the cervix, and into the uterine cavity. And that allows us to look for things like polyps, fibroid tumors, an indentation in the top of the uterus called a uterine septum. And those things are all correctable as we look at them. Instantaneously, they're correctable. I'd like to move on now. And actually, you know what? Maybe we'll stop at this point and see if there are any questions. So Monique, I don't know. I'm hoping that you can hear me. I don't know if there are any questions yet. And if there are, there are questions. Okay. Yeah. So one question is the HSG X-ray radiation safe for your eggs? And the answer is yes. I mean, to the best of our ability, it is safe. You have to understand that radiation, for example, chest X-rays, you have to get 20,000 unshielded chest X-rays in pregnancy to achieve what's called the LD50, which is the lethal dose of radiation that would kill 50% of pregnancies. So in other words, I mean, not that anybody really needs to know that number, but the point is that the amount of radiation that is released is actually very low. And this is why we like to use Austin Radiology, because they're very experienced at what's called fluoroscopy, where they use continuous radiation as opposed to just a single snapshot. They'll use continuous radiation. They know when to turn the machine on, when to turn the machine off. And that really allows us to get very good pictures of the anatomy without exposing you to much radiation. Okay, another question. Why do AMH levels go from a lower number 1 month to a higher number a few months later? Because there's variability. So I tell patients this all the time. There's a big, big, big difference between hormone assays and blood counts. If we want to know what your white blood count is, we can actually draw your blood, or even your red blood count. We can draw your blood, pass it through a machine, and that machine will actually count 7,300 white blood cells per cc of blood. So we know accurately what your white blood count is. We know accurately what your hematocrit is. But when it comes to hormone assays, it's a very, very different situation, because there is no machine that counts molecules of AMH or milli-international units of FSH. These are all relative assays. And so what we're looking at are relative values or trends. And what you'll see is variability from month to month. So if I draw your FSH level today on cycle day 3 in April, your April cycle, it may come back 7. But if I do your FSH level next month on day 3, it may come back 6 or 9. But that's all okay because those levels are still low. Same thing with AMH. We want your AMH level to be above 0.7, preferably above 1. You know, now if you have an AMH level that's really too high, 15 or so, that's potentially indicative of something like PCOS. Okay, and so we would need to know about that as well. But the bottom line is that we want to get the best handle we can on what your lab results are. But we accept the fact that there's going to be variability from month to month or over a period of a few months. Next question, what are your thoughts on a do-it-at-home fertility blood test versus making an appointment with a fertility specialist for an introductory information? I would just tell you that you've got to understand, first of all, AMH levels. Let's just talk about AMH for a minute. There are lots of different assays, lots of different ways to do AMH. We like to use this lab in Boston called ReproSource because they actually published a study of almost 17,000 women going through in vitro fertilization. And they correlated their blood test, their AMH level, with their outcome. And what they found was there was a very good correlation between AMH levels and outcome. People who had low AMHs did poorly with IVF. They had few eggs that developed. People with higher AMHs did very well with IVF in general, and they had lots of eggs to develop. So we like using ReproSource because, number one, it's the only assay that's been validated. And number two, we know how to interpret those results. We know what to do with them. I've got plenty of patients who've gone to CPL or they do modern fertility or they do some online, some kind of test. They bring me the results and I say to them, you know what, I really need a ReproSource test because I want to know something that I can rely on. And it's unbelievable how often the results from CPL or modern or somebody are so far off of the ReproSource results. So, you know, I'm not here to, I don't have any stock in ReproSource. I don't have any interest in it. I just tell you it's the best test out there and the most reliable and the most usable. So that's what I would do rather than doing something at home, you know, a little blood test that you send in. It's potentially a problem. What would you recommend for a lesbian couple who has PCOS and Hashimoto's disease? Well, lesbian couple, non-lesbian couple, doesn't matter. You need to get those conditions under control. So Hashimoto's disease is an autoimmune disease that affects the thyroid gland. It can initially cause one to become hyperthyroid. And then eventually, as the thyroid burns out because of the inflammation, people typically end up being hypothyroid. So you kind of have to ride the ride. You know, if you overtreat at the beginning, you may end up in a different place and not have such a good outcome with your thyroid long-term. So you kind of have to wait it out and see where you're going to settle out. But most people with Hashimoto's disease end up being on thyroid hormone replacement. As far as PCOS goes, we'll talk about that in a few minutes. Actually, you know, if you want to, we can talk about that now. But PCOS it stands for polycystic ovarian syndrome. In the old days, it was a triad of symptoms. So women would have to have amenorrhea, which means they wouldn't have periods at all. They would have obesity, and they would have hyperandrogenism. In other words, their testosterone levels would be so high that typically they had a lot of facial hair, typically more hair on their face than I have. And that was the triad that initially defined PCOS. But then a lot of other studies were done on PCOS, and it turns out that PCOS is a small subset of women who just don't ovulate regularly. So a lot of OB-GYNs, a lot of non-OB-GYNs, just other physicians, family physicians, for example, don't have a very good understanding of PCOS. And when a woman doesn't ovulate regularly, they'll say to her, oh, you know what, you have PCOS. Well, that's usually not true. In fact, most studies suggest that only 10 to 25% of women who don't ovulate regularly actually have PCOS. So PCOS is a very definite, defined diagnosis. And it's very important to be able to know if you have it or if you don't, because there really are long-term implications. If I say to somebody, you actually have PCOS, I'll tell you how we diagnose it in a second. But if I say to you, you know what, you actually have PCOS, what I'm saying to them is not only that you don't ovulate regularly, but you also have an increased lifetime risk of diabetes requiring insulin, high blood pressure, and potentially heart disease. So it's very, very important that we treat and we diagnose PCOS correctly so that we can treat it correctly and minimize the occurrence of these long-term problems. I was going to say something. Oh, how do we diagnose PCOS? So again, in the old days, we would just do an ultrasound and look and see lots of follicles within the ovary. But we know now that you can have a polycystic ovarian appearance without actually truly having PCOS. So what we're looking for to diagnose PCOS is we're looking for the presence of something called a metabolic syndrome. And the metabolic syndrome is where you don't process glucose appropriately. So the best test to do to define PCOS, not only looking at androgens like testosterone, DHEAS, things like that, But we also look at what's called a 2-hour glucose tolerance test. And this is a relatively simple test where you'll go into the laboratory fasting, you get your blood drawn, they have you drink Gatorade and draw your blood an hour later and draw your blood an hour after that. So we then look at these 3 blood tests, 0 time, time 1 hour, and time 2 hours, and we try and determine if those levels are normal or if they're not. To have a diagnosis of PCOS, you have to have at least 2, if not 3, of those test results be abnormal. And that cinches the fact that you truly have PCOS. And once you're given a diagnosis of PCOS, not only do we put you on pills to make you ovulate regularly, but we also put you on another medication called metformin that helps you metabolize glucose appropriately and help control the situation. So I hope that answered that question. Next question, do you offer weekend first-time patient appointments? Not typically. If you have a specific situation, we are happy to work with you. We are open 7 days a week, 365 days a year except leap year, as I say. We're open 366. We are one of the only fertility practices in the country that never closed a single day during COVID. So we've stayed open the entire time. Our IVF lab stayed open the entire time. We're very proud of that. If my partner has a low sperm count, what is a way to help the count get higher? There are lots of things that we can do for that. So the first thing we do, if you have an abnormal semen analysis, is we repeat it. Because frequently, one abnormal semen analysis is followed by a normal semen analysis. Again, there's variability here in sperm production. And you have to understand, we'll talk about sperm probably a little bit more in detail in just a few minutes, but from the time it makes a sperm, or from the time a guy makes a sperm until the time that sperm is ejaculated, it takes between 90 and 108 days. And that's because those sperm have to navigate their way through the tubules in the testicle. They have to navigate their way through the tubules that lead from the testicle to the vas deferens. Those are called the epididymis or the epididymal tubules. Then they have to come through the vas deferens before they're actually ejaculated. So sperm are in the process of being made for about 3 to 3.5 months before they ever see the light of day. And during that period of time, if you have a fever, if you have an illness, if you have a scrotal injury, the flu, anything like that can adversely affect your sperm count. So the first thing we'll do if we get an abnormal semen analysis is we'll repeat it. If the test comes back normal, we can pretty much stop there because it is highly unlikely for a guy who has significant male factor infertility to all of a sudden produce a normal semen analysis. The converse of that is not true. It's very common for a guy who's got normal fertility to occasionally have a bad day and produce a bad sperm specimen. We know that if you ejaculate too frequently, for example, if you ejaculate 3 times within a 24-hour period, there's typically little to no sperm at all in the ejaculate. And guys confuse the ejaculate that comes out with sperm. Only 5% of the concentration of what's in the ejaculate is actually sperm. 95% of what's in semen is secretions that come from the prostate, come from the seminal vesicles, come from other types of organs. So there's a lot of stuff in semen besides sperm. So the question is, how do we improve sperm counts? There's lots of things we can do. One thing we do, we are not trained urologists. We work with some of the finest urologists in Central Texas. We would refer you to see one of the urologists to make sure there's not an anatomic abnormality. We would also potentially draw your blood. If your sperm count is mildly depressed, and let's talk about normal for a minute, a normal semen analysis means you have at least 20 million sperm per cc of semen. You have at least 50% of those sperm that are alive and swimming. That's called motility. And you have at least 15% of those sperm that have a normal shape. That's called normal morphology. So you can say to me, well, wait a minute, I can have 80% of my sperm that have an abnormal shape and that's still normal? And the answer is yes, because we know that most sperm have an abnormal shape. We also know that most sperm are chromosomally abnormal. And so these are important things to remember. So if a guy has got a mildly depressed sperm count, we'll draw blood, we'll look at his FSH, his LH, and his testosterone level. And it may be that he has a very low testosterone level. Guys need to make their own testosterone in order to be able to make sperm. Now, you could say to me, as a lot of people do, well, hey, if my sperm count's low, maybe I need to take testosterone. Absolutely wrong. Giving testosterone to a man is analogous to giving a birth control pill to a woman. So what happens when we give high-dose estrogen to a woman? She stops ovulating. What happens when we give high-dose testosterone to a man? He stops making sperm. So it's very important not to self-medicate. It's very important if you have a low sperm count or you feel like you're fatigued and you go to a low testosterone center or a men's center, it's very important that you tell them that you're trying to conceive, because otherwise they might give you testosterone, which is going to make it much more difficult, if not impossible, for you to conceive. So how can we fix a low testosterone level if I'm saying to you now we can't give testosterone? The answer is we use the exact same pills that we give to women when they don't ovulate regularly. So we give Clomid or we give letrozole, Femara. And when we do that, those drugs act on the hypothalamus. It tells the brain that there's no testosterone around. The brain sends a signal to the pituitary gland and tells the pituitary gland, hey, wake up, we're not making testosterone. Or in a case of a woman, hey, we're not making estrogen. So what do? Well, the pituitary gland makes more of that hormone called FSH that causes sperm or eggs to develop. And it also makes a hormone called LH, which causes testosterone levels to go up. So this is a way that we can give a guy, without giving him testosterone, we can take a guy who's got a low testosterone level, give him Clomid or give him Femara, raise his sperm production, and raise his testosterone level. So that's what we do. That's how we treat it. Next question. Do you offer sperm since I'm a single female? And the answer is we don't. What we do is we would refer you to one of the major sperm banks in the country. So California Cryobank, Fairfax Cryobank, and Zytex. Those are the three leading sperm banks in the country. There's also a Seattle Sperm Bank, and we would refer you to one of those programs to get sperm. And then they know us. We've been around for a very long time. They've been around for a long time. We work very, very closely together. You would purchase sperm from them. They would ship it to us, and we would go from there. Is there enough information about the COVID vaccine and the effects of that vaccine moving forward with IVF? This is a totally separate kind of train of thought. I'll answer the COVID question. I will tell you that there's going to be a webinar coming up on COVID and infertility and how you get pregnant. There's also a seminar that's going to happen on Sunday, put on by the Fertility Foundation of Texas. I'm actually giving a talk at that seminar at 11 o'clock in the morning. If you want to hear it, all about the COVID, the virus, and the vaccine. And we're going to go through all of that. But I can tell you right now, we don't have any long-term data. COVID's only been around for a little over a year. The vaccines have only been around for a little over 6 months. We don't have any long-term data whatsoever about the vaccine. The data that we do have suggests that it is important and that you should take it. So what do we know? What do we not know? Just briefly, and then I'm going to get back on topic. What we know is that COVID can be bad. And it's not predictable. When you get COVID, if you got it from a family member and your family member had a very mild case of COVID, that is no guarantee that you'll also have a mild case. So the type of COVID you're going to get and the symptoms and the severity of the disease that you're going to get is not reproducible or is not, we can't guess. We don't know what's going to happen. And yet we also do know that if you get COVID during pregnancy, it's worse. So it's known that if you get COVID in pregnancy, it's worse. There's no evidence yet that either the virus or the vaccine affect fertility. And this is why the Center for Disease Control, the American College of OB-GYN, and the American Society for Reproductive Medicine all suggest that if you are pregnant or if you're trying to get pregnant, that you should be vaccinated, fully vaccinated as fast as possible. Next question. Do you recommend that my OB-GYN order specific blood work before I come in from my new patient appointment at TFC? If you are seeing somebody already, if you're seeing your OB-GYN already, if you could get them to draw a ReproSource test on you on cycle day 3, very helpful. If you could ask them to order a semen analysis, have you come over to Ovation, to the laboratory that TFC uses, and get a semen analysis, again, very, very helpful. I think those things would be really important. We would like to do the rest of the evaluation because we do things a little bit differently, even vaginal ultrasound. I mean, I have patients all the time to say, well, gosh, my OB-GYN did a vaginal ultrasound. Do we really need to repeat it? And the answer is, as much as we really don't like repeating anything, we are so cost conscious. We tried it. We know fertility treatment is expensive. We know that, unfortunately, a lot of insurance still doesn't cover infertility treatment. And so we try and do anything we can do to keep the costs down. But ultrasound is something we've got to repeat because we have to know ourselves. We're looking for different things. We need to find subtle findings, the shape of the cavity. You may have a uterine septum that your OB-GYN would have missed, not because they're incompetent, but because they're not used to looking for it. A cyst in the ovary may to your OB-GYN appear to be a simple cyst. We see echoes that make us think about a dermoid cyst. or endometrioma, something like that. We see a dilated area off to the side of the uterus that your OB-GYN may think, well, that's just blood vessels that are going and feeding the uterus. And we may know, no, it's a fallopian tube that's severely damaged. So for those reasons, we would ask you just to get a semen analysis and just to get a day 3 blood test, preferably using the laboratory which we like, which is ReproSource. What if you're in states, if your insurance states that you have to wait a year before you see a fertility specialist? Again, you're welcome to contact us and we're happy to help deal with that. If you're 28 years old and you have no known fertility factors, we're not going to be able to help. If, on the other hand, your husband had a testicle removed because of testicular cancer, we'll be able to help. If he had a scrotal injury, playing football or sports in high school, we'll be able to help. If you don't have regular cycles, we'll be able to help. If you've had gonorrhea, chlamydia, there's reason to think you've got a tubal disease, you're known to have severe endometriosis, you have big fibroids, we'll absolutely be able to help. There's no reason that you should have to wait for a year. Next question. I'm preparing to start IVF. I'm turning 34 in the fall. We're debating on starting this year or next year. Would you recommend to start the process or 33 or 34? Does 1 year really matter? I've been tested on everything, including Hsg, and everything looks normal on my end. If you've had a ReproSource test and your ovarian reserve looks good, looks normal, and you've had a vaginal ultrasound and your ovaries look normal, and you're having regular cycles, I really don't see much of an issue waiting whether you're 32, 33, 34. I think that's fine. Now, ideally, we want to work with you as soon as possible because many of you want more than one baby. And the challenge is going to be that if you get pregnant if you could get pregnant when you're 32, but you choose to wait till you're 34 or 35, now it takes a year to get pregnant. You're 35 or 36. By the time you deliver, you're 36 or 37. You breastfeed. You may want to take a year or two off. Now you come back and see us and you're 39 or 40. And now we unfortunately have to have a very different conversation than we would have had sooner. So from a fertility specialist perspective, I can tell you that even though you should absolutely, based on the parameters in this question, you should absolutely be able to conceive at 34 almost as well as you can at 32, probably no significant difference. You need to think long-term about what are your goals because that's really going to make a big difference. Next question. Boy, these questions are great questions. I'm 42 years old. I have a 23-year-old son. I've been trying to get pregnant for the last year. I tried one IVF cycle. They told me I had a lot of eggs, which was great. But at the end, only one fertilized and still didn't work. Should I get a second IVF cycle or should I give up? You should get some answers. That's what you should do. So, I understand that you're 42 years of age, and I understand clearly that has an effect on your eggs. But to get a lot of eggs, I don't know exactly what a lot of eggs mean, but when only one egg fertilizes, there's a problem. Either there's a problem with the sperm, or they didn't do ICSI, which is a procedure where when guys have a low sperm count, we can pick up a single sperm with a microscopic needle and inject it directly into the egg itself, markedly raises the chance for fertilization. And it may just boil down to the fact that your partner's got great sperm. They did ICSI, but your 42-year-old eggs or 42-and-a-half-year-old eggs just didn't work very well. And that, unfortunately, is a possibility. But what you really need, I would encourage you not to just rush into another IVF cycle. Get some answers. Can you speak about pregnancy after a cone biopsy? I was able to get pregnant with my first son after a month. I then had stage 1 cervical cancer. I had to have a cone biopsy in 2017. Since then, we haven't been able to get pregnant. I've just been putting off making an appointment. I would encourage you to come in and let us evaluate your cervix. So why is the cervix important? Well, the answer is the cervix makes mucus that the sperm use like a ladder to get from the vagina into the uterine cavity. So when a couple has intercourse, millions, maybe tens of millions of sperm get deposited in the vagina. And those sperm then have to make it from the vagina through the cervix into the uterine cavity so they can then swim out into the fallopian tube, find the egg, and cause fertilization. When you do a cone biopsy, the purpose is unfortunately not to preserve your fertility. The purpose is to save your life. You have an abnormal enough pap smear that your OB-GYN is worried may lead or may become cancer of the cervix, which is a very, very serious condition. So they cut out typically an ice cream cone shaped piece of your cervix. And unfortunately, sometimes when they do that, they cut very deep, and that takes out a lot of the mucus producing glands that line the cervical canal. And when that happens, there's not a lot of mucus production, and it makes it very difficult and very challenging for sperm to get up inside the cervix into the uterine cavity. So you may need something simple like intrauterine insemination, IUI. And that may be all that it takes to help you get pregnant. What is the definition of infertility for women aged 35 to 40? I think I misspoke at the very beginning. The definition of infertility is a year or more of unprotected intercourse not leading to pregnancy if a woman is over 35. In other words, including 40. I think at the beginning I might have said over 40. I meant to say over 35. I'm sorry, and I blew it again. I'm sorry. The definition of infertility, if you're over 35, is 6 months or more of unprotected intercourse not leading to pregnancy. If you're under 35, the definition is 12 months or more not leading to pregnancy. So that's the definition of infertility. So I think we've exhausted the questions for the time being. We've got a few more minutes to talk. I think there's a couple other things I'd like to talk about. Talked about the Hsg already. I talked about laparoscopy, how you know if you're ovulating. We've talked about the basics of that. If you're having regular cycles, 28 to 30 days, cramping with your period, maybe some breast swelling and tenderness during the month, all of those things you can pretty much take it to the bank. What we like to do is we like to ask our patients to go to the store and buy an ovulation prediction kit. Ovulation prediction kit is relatively inexpensive. We like Clear Blue Digital, not the Clear Blue Advanced. This is a case where the more you pay, you don't necessarily get any more for your money. And in fact, it becomes confusing. We like Clear Blue Digital because you'll have nothing on your stick or you'll have a smiley face on your stick. And when you get a smiley face, that says that, or what that means is that there's a 95% chance that within the next 24 hours, you'll ovulate. The Clear Blue Advanced, unfortunately, has a flashing smiley face that leads to a more rapidly flashing smiley face and then a solid smiling face, and that confuses people. So we ask you really not to do that. How hormones interact, we've really talked about that. Assessing male factor, let me just go over that again because it's so important and I do want to focus on that a little bit. We know that male factor is involved in half of the cases of infertility now. So what we'll do with the guy, we actually have changed our entire practice 15 years ago. So now we don't just ask questions of the female when she comes in, but we also talk to the male. And we'll ask the male the same kind of questions. You know, how old were you when you first started ejaculating? How old were you when you first had sex? Any history of any sexually transmitted diseases? Any medical illnesses? For example, diabetes, insulin-dependent diabetes is the most common cause of erectile dysfunction in the United States. Other causes of erectile dysfunction can include high blood pressure medicines, some medicines for esophageal reflux, medicines for difficulty with urination, lots of other medicines that can adversely affect a guy's ability to get an erection, maintain an erection, or ejaculate. So we'll talk about all those issues as well. A normal semen analysis, what we like to do, first of all, is have guys give us a specimen between 2 and 5, with somewhere between 2 and 5 days of abstinence. We like to get the specimen delivered to the Ovation laboratory within an hour or so of the time that the specimen was collected. This gives us the best likelihood of getting a good, accurate specimen. And when we examine the specimen under the microscope, we look at a bunch of different factors. We look at volume. You know, it's embarrassing, but sometimes, guys aren't used to collecting a sperm specimen in the cup, and sometimes they miss. And that's important for us to know because it can change the way we interpret a semen analysis. So if a guy produces a sperm specimen with very low volume, that could mean that he's got a partial vas obstruction. It could also simply mean that he just missed the cup. So we'd like to have between 2 and 5 days of abstinence. We'd like to get specimen within an hour of the time it was collected. We look at 3 basic parameters. We looked at the sperm concentration. That should be at least 20 million sperm per cc of semen. We look at the percent motility. At least half of the sperm that we get should be alive and swimming. And we look at the normal morphology. At least 15% of the sperm should have a normal oval-shaped head, a single midpiece, and a single tail. And that tail is what moves to propel that sperm through space. So it's very, very important. What about the effect of age? I think we've touched on this a little bit. I've got my cheat sheet here, some notes, things I wanted to make sure that I discussed. But we talk about the effect of age. As women get older, their chance for pregnancy goes down. And unfortunately, their risk of miscarriage goes up. And it's all because of the same reason. It's all because of damage within the egg. So why is it that the egg is so important and the sperm is not so important? Why is it that guys can father pregnancies into their 60s and 70s, maybe even 80s, and women, need to have good family planning in their 20s and 30s, and by the time they're in their mid 40s, it's really over unless they want to use donor eggs? The answer is because everything happens in the egg. So to take you back to high school biology, when you might not have been paying attention, When an egg is fertilized and it divides, okay, when one egg becomes two eggs, or one cell becomes two cells, sorry, when the egg cell becomes two cells, what happens is that division doesn't happen by magic. So what happens, first of all, is the chromosomes in the middle of that cell line up and they duplicate. So now instead of having two sets of chromosomes, you actually have four sets of chromosomes. Okay, and then those chromosomes are pulled apart. And they're pulled apart by something within the egg called the spindle apparatus. That spindle apparatus is what attaches to the chromosomes. And when that egg goes, it's fertilized now and it goes to divide, and half the cytoplasm goes this way, half the cytoplasm goes that way, we want to make sure that half the chromosomes go this way and half the chromosomes go that way. But unfortunately, as eggs get older, that spindle apparatus is more prone to breakage. So now if you have these chromosomes lining up in the middle and part of the spindle apparatus breaks, now instead of 46 chromosomes going this way and 46 going that way to create two normal daughter cells, maybe you have 47 chromosomes go that way. That's Down syndrome or trisomies. Maybe you have 45 chromosomes go that way. That's Turner syndrome or monosomies. And we know that as the egg ages, that spindle apparatus is more prone to breakage. And as it breaks, that leads to problems that can decrease the chance for successful pregnancy and raise the risk of miscarriage. Having said that, people ask all about Down syndrome. Down syndrome is very frightening to a lot of people. And you have to understand what the numbers really are. So at the age of 40, let's back up, the age of 35, the chance of a woman having a baby with Down syndrome is about 1 in 365 or so pregnancies. By the time that woman is 40, the chance goes up to 1 in 100 pregnancies. Now, you can read the same headline in the New York Times. Woman's risk of delivering a baby with Down syndrome triples from 35 to 40. That's true. But it could also say the risk of having a baby with Down syndrome between 35 and 40 increases from 1/3 of 1% to 1%. That's also true. It's the exact same thing without the hysteria and without the drama. So if I say to you, I've had 40-year-olds, it seems like most of my practice is over 40-year-olds these days, which is fine. It's challenging. But if when my 40-year-olds say to me, oh my gosh, is it even safe for me to have a baby? Because, what if I have a baby with Down syndrome? Well, I tell them if I line up 100 pregnant women who are 40 years of age in my office, only one is going to have a baby with Down syndrome. And now with early detection, you'll know in advance if you will or if you won't. If you're really concerned, we can do in vitro fertilization, do pre-implantation genetic testing, and we can determine if an embryo is affected with Down syndrome or not before we even put it into your uterus. So you can make the decision as to what to do with that embryo. Do we transfer? Do we not transfer? I have a lot of questions that have come in now. So I think I'm going to go take a couple of those, and then we're going to have to wind up. Question number one, what are the options for correcting abnormal sperm morphology? This is a tough one because there really is nothing that we can do to improve sperm morphology in general. A lot of urologists believe that if a man has a varicocele, a dilated vein that drains the testicles, that correcting that varicocele may improve sperm morphology. There are some studies that suggest that does happen. There's some studies that suggest that it doesn't happen. There's no medicine that we can give your partner to cause his sperm count or his sperm morphology to go up. What we can do is we can do intrauterine insemination, IUI. We can process the sperm and we can pull out a much higher concentration of normal appearing sperm. We can also do in vitro fertilization if we need to, even with ICSI, where we can identify a single sperm with normal shape and use that. I'm not infertile, but my husband doesn't want to get tested. Do I have any advice? Fertility, family building is a team sport. It just is a team sport. And so I would encourage your partner to get tested. It's not a big deal. It's not embarrassing. It's very discreet. They can call Ovation. They can come by Texas Fertility and get a cup. They can call Ovation. They can produce a specimen at home. You can help produce a specimen. Anything other than intercourse and withdrawal is fair game. So you can make it, to be somewhat at least enjoyable or less stressful. And I'm hoping that maybe those things will matter. Maybe those things will maybe encourage him to go ahead and try and get tested. I've heard that Hashimoto's disease can cause problems when trying to get pregnant, but is there a real issue with this? Hashimoto's disease can be a problem, yes. So it's important that Hashimoto's disease be treated and be treated appropriately if necessary, with thyroid stimulating hormone. I'm sorry, with Synthroid to correct thyroid stimulating hormone and make that happen. Let's see. I think those are the end of the questions that we have now. So let me go back for the next 3 minutes or so and see if there's anything that we need to talk about. How about lifestyle factors? We didn't touch on that yet. So I asked all the time, well, what are things that I can do that are going to raise my chance of successful fertility? And there's a lot of things that you can do. One thing is weight. So we know that the greater you are, the more you are over your ideal body weight, the more of a challenge it's going to be able to conceive. So getting as close as possible to your ideal body weight is very important. We know that adequate nutrition is very important as well. If you're too much over your ideal body weight or even too much under your ideal body weight, that can interfere with your ability to ovulate and interfere with your ability to successfully conceive. Tobacco, one of the worst things you can do for fertility. I tell patients all the time, you know what? If cancer and heart disease isn't enough to get you to stop, what if I was to tell you that if you smoke regularly, you're going to go through menopause 3 to 5 years earlier? It's like, you can see the light bulb goes on over their heads and it's like, oh, wow, maybe I should quit smoking. I'm thinking whatever it takes. So it's important to not smoke. Caffeine, we get asked this all the time. We live in a coffee culture. Up to 200 milligrams a day of caffeine, which is a little more than a cup of regular Starbucks coffee a day, is okay. Above that, it does increase your risk of miscarriage and decrease your likelihood of successful pregnancy. Alcohol to excess is problematic. I don't want anybody to pick at me, but I can tell you there is no published data that a glass of wine here or a margarita there, even in pregnancy, is problematic. People ask me all the time about stress, and that's a great question. I wish there was a stress scale, because then I could say to people, oh, you know what, you're 86.3 on the stress scale. We got to get you down below 62.5. But there's no stress scale. It doesn't work like that. We would like for your stress levels to be low. I've been asked over and over again, could you just write a note to my work and tell them I need to take 6 months off because I'm trying to get pregnant? I can't do that. If I could, I would probably do it for myself, but we can't do that. So we would encourage you just to do the things that you can do to try and reduce your stress level. More questions. Are there supplements or diets that would help if I'm trying to get pregnant? Supplements are really, unfortunately, very expensive, and most supplements don't have any data behind them. I'm very skeptical of supplements, and I get asked about all of them all the time, every single day. What I would encourage you to do is to get on a prenatal vitamin. A prenatal vitamin will not help you get pregnant. It will just make sure that when you do get pregnant, that you're healthy, you have all the vitamins in place. And one thing that a prenatal vitamin can do is it can absolutely significantly decrease, if not totally eliminate, the risk of spina bifida. So we know that spina bifida occurrence is related to folic acid concentrations. Prenatal vitamins are loaded with folic acid. And so we know that if you take a well-rounded, good prenatal vitamin, that we can almost eliminate your risk of spina bifida. Can I do acupuncture when trying to get pregnant? Absolutely. There are very good data that suggest that acupuncture is beneficial. There's only one study that I'm aware of that shows that acupuncture is detrimental. And I think that data is kind of questionable. Most studies of acupuncture really don't show much of a benefit or detriment. But, I've got a lot of patients who swear by acupuncture. I work with a lot of acupuncturists in town. I find them in general to be very reputable, very helpful, very concerned about what they can do to help their patients and help our patients conceive. If I have one fallopian tube blocked, but the other one is fine, can I still get pregnant? Absolutely. But here's the caveat. You need to find out how that tube was blocked. Was it blocked because when you were younger, somebody went in and took it out because you had a mass? Or was it blocked because you had gonorrhea or chlamydia? Those typically do not infect one fallopian tube. And even though one fallopian tube is blocked and the other looks like it's normal or looks like it's open, if we go in there laparoscopically, we may very well find scar tissue or damage around the end of that fallopian tube that you think is normal. So if you have a blocked fallopian tube and you don't know why, you need to see a specialist. You need to see a reproductive endocrinologist. Weird family question based off your last comment. If I'm turning 38 in August and desire more than one child, would you recommend jumping to IVF to increase the chance of twins? Quite the contrary. We do everything we can do with IVF these days to prevent the transfer of more than one embryo. Especially when people do pre-implantation genetic testing, we will only transfer one embryo if it's euploid, if it's chromosomally normal. Twins look great on Christmas cards when they're dressed alike in the mall. But when that baby is born at 26 weeks, because your uterus can't expand anymore. And now you've got a baby that's in the intensive care unit. And oh, by the way, there are 2 of them. And when the cost really starts to mount, and then when at the end of the day, your reward is that you get to take home 2 children that, please God, are not brain damaged, not lung damaged, not intestinally damaged, and that are going to be functionally normal for the rest of their lives, it's still a challenge. I mean, raising 1 child is a challenge. Raising 2 at the exact same time, at the exact same age, is very, very, very stressful. It takes a huge toll on marriages. It's very expensive. Just to give you some data, the average cost of delivering a single baby in the United States 5 years ago was almost $19,000. The average cost of delivering twins, $98,000. Triplets, almost $400,000. Why does that increase so astronomically? The answer is because the most expensive bed in the hospital, an entire hospital, the most expensive bed is that bassinet in the neonatal intensive care unit. And so costs will really ramp up very significantly. And this is not a cost issue, I get that. But what I would ask you to do is think about this a little differently. If you're 38, maybe we do IVF so that we can get that 1 chromosomally normal embryo, but maybe you have extra chromosomally normal embryos that we can freeze. And then when you come back and you're 40 or 41 or 42, you have the same chance of having a baby as that 38-year-old did who produced that chromosomally normal embryo. So I think that's a great place to stop. I'm tired. I'm sure you're tired. It's 7:30. We've all had long days. Again, Dr. Kaylen Silverberg, Texas Fertility Center. I would strongly encourage you to call us if you have any questions. Strongly encourage you to come see us. We have offices all over the Central Texas area. We go from Round Rock. We go, I think, oh gosh, I can't remember now if it's 131 miles, maybe more than that now. But we go from Round Rock to North Austin, to Central Austin, to South Austin, to New Braunfels, to San Antonio, now down to Corpus Christi. So thank you so much, everybody, for joining. I really appreciate it. I hope you learned something. I hope that you will join us again. We do this once a month. And thanks so much for your time. Sure appreciate it. Have a great night.